The average is around 28, and it can change cycle to cycle. I mean, not necessarily a big week all the time, but you can be like 26, 29, 30. So sometimes it can fluctuate a lot. And during their reproductive life, like 12 to about 52, it will change as well, okay? So I have patients like, oh, I used to be 25 days and now I'm over 32, or it can fluctuate like that during lifetime. When you get in the 40s, it's where it gets a bit more messed up because the perimenopause. And just to clarify, perimenopause is all the years before you get menopause. Menopause, it's a year without bleeding. It's not a perfect definition because sometimes you can have a year without bleeding because you're menopause, but that's the best definition we have now. And we have perimenopause is divided in two portions. We have the early perimenopause is when your cycle starts to be different by about 7 days, so more than 7 days difference. And usually it's more shorter than longer. We see people having 2 menses a month, or sometimes being a little bit longer, so it's a little bit really irregular. People can start to have symptoms like hot flashes, mood swing, more depressed mood, more anxiety, more joint pain. It's all symptom related with perimenopause, menopause. And that, we don't know exactly how long it can stay. It could be a few years. There's no real definitions of how long it is. It could be very variable depending of people. The late perimenopause is when you start to skip cycle. Usually when you're 45 and over, and we say when you have more than 60 days between your cycle at least once, we can say usually, if we rule out any other reason, that you are in the late perimenopause, and that is 1 to 3 years. So when you get there, like, 1 to 3 years to go. You may have more symptoms of perimenopause. The PMS, I forgot to say, are more severe when you're in perimenopause. So a lot of people say my breast is more hurting, my mood is more all over the place. It's really like a roller coaster. Your cycle sometimes is normal, sometimes not. And it's because your ovary is not functioning super well. So the pituitary gland, which is the gland that stimulates your ovaries, some have to work really hard, and sometimes what it does, it makes you ovulate super closely and having really short period, and sometimes the ovary is not working at all, and then you miss cycle. But your hormones can be super high at super low, so it's why all the PMS and the symptoms are present. Menopause is around 52 years old. The bleeding also is usually more heavy, not usually, I'm biased, I see a lot of people with that, but they can be more heavier as well in the 40s and over. Normally, bleeding, it's about 10 to 80 millimeters per cycle, okay? It's easier for people who has a Diva Cup now to know exactly how much they lost, because some of them have some measuring. But they say it's about like, I was doing 2-3 tablespoons. That's the average for 35 millimeters, which is about the average. But some go up to 80. When they check for pads or tampons, they say it's about 6 pads. But when they say 6 pads, it's like soaking through all of it, okay? So it's not like half of it or something like that. Because we know women, we don't wait usually that it's soaking before we go. So when we change, go to the bathroom. So it will be more than 6. But if you wait that it's really soaked, it's about the average is 6. But if that's 35 millimeters, if you go for 80, then it could be like up to 12 or 13 pads per month. But really, really, really soaked, like I said. Tampons, it's about the same thing. Apparently, I never checked, but apparently on the package they say how many millimeters the pad or the tampons can have. I honestly never checked, but they say that you can do that. But like I said, the Diva Cup, it's easier because you can have, or you can, if you really want to measure, you can take it and measure with a tablespoon or a teaspoon. When you're outside that range, usually it's where it's more heavy. I'll be honest, I see rarely patients complaining because it's too light. I had 1 or 2 that I saw for that, and it's not frequent, but too heavy, it's more frequent. Normally, for us gynecologists, we say, okay, it's something that it's significant, I mean, that need to be investigated if it's more than 6 months. Because again, different things play on the cycle. Stress, immunity, even COVID vaccine can make for a few months heavier and more spotting. So usually if it's more than 6 months, it's where we start to say, okay, we have to check what can cause the abnormal bleeding. If it's just 2 or 3 months that it's heavier, usually we say, okay, wait a little bit to see if it's persistent or not. Different things can cause increased bleeding. Could be one of the common things is your thyroid glands. If your thyroid gland is not working well, it could be from heavier bleeding, irregular bleeding, to light bleeding, depending if it's hyper or hypothyroidism. So that's the one things we check mostly. And depending of the age, sometimes we have to make sure there's no abnormal cells, but it's usually 40 years and over that we have to do some sample of the cells that you shed when you have your bleeding to see if there is anything abnormal. But usually we can do mostly blood tests and see if it's we have a specific reason. Sometimes we don't find the reason, honestly, which I hope I could find it for everybody, but we rule out everything, and if everything is fine, then usually we go with the different options that we can have for bleeding, which is a lot more now that we had in the past. So I see a lot of patients, oh, my mom had a hysterectomy, but in the past, we didn't have a lot of options. So yes, like if you count like 20, 30, 40 years ago, it ended up a lot with surgery. But now we have a lot of options that are non-surgical or what we call minimally invasive or day surgery, things like that, that are helping bleeding. One of the problems we're having now is to have access to surgery. As a gynae, we're cut and cut and cut and cut. So when I first started to work here in 2004, I had a day a week. Now we have a day a month. When it takes 2 or 3 hours to do a surgery, sometimes you do 3, 4 patients a day. That's it. So it's really, really minimal. So thank God we have other options, but it's why sometimes I explain to patients it's good to see if anything else works, because having surgery, we need to help you before surgery, basically. If you want to have some relief in between surgery, we have to try something else, because surgery is really long. So that's for the quantity of bleeding, and clots are normal. More you bleed, more that will tend to do clots, so don't worry about that. But they're, I would say, normal usually, unless, like I said, it's more the quantity of bleeding and it could be abnormal. For pain, some pain is normal as well, but pain is extremely subjective. So it's really hard. They have like scale with pains that you can ask people, but even then that can be subjective, because some people will tell me that's the worst pain I had, and some people will say for the same pain, I can live with that, no problem. So it's really hard to assess for pain. Which is normal. It's normal to have pain during your cycle. It's part of it is away from the uterus when it contracts to expel those cells that need to get out. It's the same kind of contraction when you have a baby to push the baby out, so it expels the cells, but also all the products that came with that blood cells create some inflammation. So the inflammation created by that brings some pain, but also all the fluid retention, some more gas in your bowel, because we know that progesterone can create more constipations before your period, so that's normal as well. You have more gas, you feel more bloated, and before it passes it all, you can have more pressure, more pain because of that. The pain is usually more in the abdomen, can be in your lower back and your legs, so that it's considered as normal. Which is considered for normal is mostly during period, or it can start 1 to 2 days your period to have pain, and usually you have like on and off pain. I mean, it's always a bit there, but you have like period we have like more crampy, that it's more severe, and usually they said it's max 10 minutes max when it happens, and it come in wave. It should not be a constant like severe pain all the time. So when it's normal, it's usually a wave of cramping and like a bottom of always like almost like a toothache. I mean, you always have like a discomfort a little bit, and that is what is normal. What is not normal is when the pain is more than 2 days before your period, or more than extend after your period is done. If you have pain when you go for bowel movement, and when you pee, and everything is worse when you have your period, it could be abnormal. But the normal pain, like I said, can vary patient to patient. What to do for those kind of pain? Lifestyle. I don't know if you have a pen. I just found a really, really good website, because there's a lot of crap online, so it's good to have a good place. I wrote it here because I find it was really informative about what is normal, when to consult, and if you go through, you can have link for like pain, bleeding, and a lot of things. It's www.menstrual is it? Not underscore, but slash. I'm like this. Menstrual /matters, matters.com. And they have normal things, and also you can link of different cause. Because when the pain is not normal, what it can be? There can be a lot of reasons. Gynae has non-gynae, okay? One of the common causes that people think is endometriosis, okay? And they have a link there for endometriosis, and I read it, and I found it was a really good explanation for patients. So endometriosis is the cells that usually shed when you have your bleeding, the endometrial cells. They get implanted in different places on your pelvis. There is 4 or 5 different theories, but the most common theory is that it passes through your tubes and goes set in the different places in your pelvis. And they react to the hormones as the cells inside. So, they get swollen close to your period, they can bleed, and there's no way for the bleeding to go. So it can create inflammation and pain that can be more constant and more irregular depending on how many you have and how severe it is, because there's a big range of severity you can have. You can have pain with your bowel movement if it's close to the bowel, because it go often like the gravity, like in the bottom area, so close to the rectum. You can have pain when you go pee, if you have some close to your bladder, but it creates a lot of pain with your period, and it can create as well pain with when you have sex. It will be more typical to be deep pain, so not the pain at the entrance of the vagina, but more deeper when it touched like the area where you could have some implants, we call. What we see though, when it's been a while, because average people to go see for that and be assessed and be treated, it's almost 7 years. That's the study shows. So most of the time when I see people, they had the pain with intercourse, which is deep, we call, and they have now the pain at the entrance of the vagina, because your body, when you have pain, is like, you don't get in. So the muscles at the beginning of the vagina, unconsciously, even if you tell yourself, relax, it's not working like that, they contract, because it's like, I don't want anybody to get in. So people develop some pain even at the entrance of the vagina because of that. It's like a muscle that doesn't go away, that a cramp, so you have pain. And you have a chair us, at some point it's painful. It's the same thing, it's getting some pain, and then you end up having pain for that, and pain because of the endometriosis. There is a ways to help that, and it's when a physio can get in to help us, but it's not an easy reflex to remove, so it's good to prevent that you get to that reflex. On that website, they talk about endometriosis and the different treatments. But again, endometriosis, it's react to hormones. So the only really good ways to prevent progressions, because it's a chronic disease and it progresses slowly. So the only way to help it's with progesterone, because the progesterone helps to decrease the size of those cells and decrease the implants and make it more quiet. So when people want to have natural choice, I will talk quickly about that. But yeah, at some point, progesterone will be needed, because that's a treatment. And we have different ways to give it now, like in the subcute in the arms, could be IUD, could be injections, could be pills, there's different ways. But it's usually the mainstay of the treatments. Lifestyle, because I saw Brianna come, so I don't know if I'm closing me over. So, lifestyle. I know it's not fun to do exercise when you're in pain, but there's multiple studies that being active, I'm not saying to go like lift 200 pounds, I'm like walking, swimming, biking, be active, help for the pain, okay? So be active. acupuncture has shown that to have some benefits for pain with the menses. Mindfulness, meditation, yoga have been shown as well to help a lot for that. There's some diet, and I know Julian will bring that, like anti-inflammatory diets that can help also some patients. I'm not saying all patients, but it's help. And there are some supplements that seems to show some improvement as well, like ginger. Ginger can help. There's some study that show that it's as good as anti-inflammatories, which is, I forgot to mention, one of the first thing you can try, Advil with Tylenol at the same time. That usually help for normal cramping, can help also for endometriosis, but ginger has been shown to help as well as omega-3. Omega-3, they said about 2 grams per day could benefits, and turmeric, it's another one, and zinc. That's the things that I said to people can help the pain, but it won't stop the progression of the disease. So it can help ease out the pain, like TENS as well. You know, those machines that help to contract your belly. TENS help, eat pads. I'm sure everybody tried that also. But that helps the pain, but it doesn't control the disease or make it not progressive. So it's why medication get in. And what is sad also is when we see people 7 years after, when you get almost to the chronic pain pattern, we have to desensitize your brain to feel the pain all the time. There's like a circuit always going on in your nervous system saying pain, pain, pain. And sometimes, even if it's the primary cause of the pain is gone, you still have this firing up in your brain saying, I'm in pain, I'm in pain. And occasionally we have to add some medication to stop this nervine connection to your brain about the pain. So there is a area of medication that we can try, but the basic is usually anti-inflammatories and Provera. And the other stuff help to not control the pain, but to tolerate the pain, decrease the pain, and make it better. But lifestyle, it's a big part. Even for chronic pain, there is a big documents about how to treat chronic pain. There's a major part on lifestyle, like mindfulness, like I said, exercise, and acupuncture, and all those things. It works, yeah, but it's things that need to be done also to help the pain. Vaginal discharge, I'll just quickly talk about that because a lot of patients I have discharge and must have an infection. Vaginal discharge is normal during the cycle, and it changes through the cycle. So it can start really thin and clear to getting more thickish and gooey almost, and sticky and more pale yellow. That's because of the change of hormones during your cycle. So that is normal. 4 to 6 millimeters per day, it's normal. And I always say to people, it's like a nose. Some people have nose dripping all the time and some none. So some people don't have a lot and some people have a lot. But there's things that make it worse, like some products with soap with perfume, or if you add irritation over, you can have more discharge, like softener, wool ball. Wool ball, it's not that great because the little fiber can get in your underwear and can irritate the skin. Like vaginal douche is not recommended for that reason, because it breaks the normal bacteria and it can create an infection. So things to be careful with that, but vaginal discharge can be normal. And like I said, some people can be heavier. When it's not normal, it's when it's more, the cottage cheese, when a yeast infection, people are more aware of that, and it's usually itchy and burning at the same time. That could be yeast infection. If it's more frothy or more like almost like a mousse, yellowish, greenish, there is an infection called trichomonas that can do that. Chlamydia, they can give some discharge, but it's mostly pelvic pain and pain with sex, or bleeding when it's like spotting when it's not normal. Could be related with chlamydia, gonorrhea. Fishy smell with a bit of yellow-green. It's more like a vaginosis, which is when different bacteria take over, because there's tons of bacteria in the vagina. The vagina is not sterile at all. It's nothing there sterile. Nothing. And the discharge is needed. It's needed to protect against infections and to make everything work normal. And it's a self-cleaning oven. I've been told, and it's true. So leave it alone. There's tons of marketing about like, oh, take this cream with this specific pH and all that. Most of the time, those products have more chemicals that doesn't help your vagina. That'll make it more irritate, more abnormal discharge. So you don't need to put any stuff in your vagina normally. The only things that sometimes I recommend, and it's not even going in the vagina, it's for some people who are prone to have yeast infection, it's probiotic that can have. And if you ask me if you have good study to say probiotic help to prevent infection, I'll say no, we don't have any good. But it doesn't hurt. And if it can help, go, and it can help other problems like IBS and other bowel disease. So I'm always say to patients, you can try that, no problem, but don't put anything else in your vagina. Vagisil should not even exist. It's the worst thing ever. It's irritate, it will make it worse. I just come back to pain because when I said IBS, when people have pain with their menses or all over the place in the cycle, we have really to assess because there is a lot of other reasons that are not gynae. And a lot of nerve connections happen in your belly. So, oh, it's my ovaries feeling, but maybe not. It's just that everything is so connected together that it feels like it's your ovaries, but it's maybe not the ovaries. It's like we do laparoscopic surgery, like we put camera in your, you put camera in your belly and check inside. When people wake up, they have pain in their shoulder. We didn't touch the shoulder. It's just the gas irritates some area, the diaphragm, the muscle here, and that refer pain in your shoulder. So it's why I'm saying it feel like it's here. Maybe the pains come from your back. There are people with back problem, hip problem that can have pelvic pain. IBS, it's a big one. I always said that endometriosis they like friends. They have like IBS and bladder pain syndrome. It's like a big trio that we see a lot. Which is IBS is when your bowel, there's nothing they will see when they do colonoscopy, when they check your bowel, everything looks normal, but it's just the function of the bowel is not normal. And it can be because, and it can increase by what you eat, and I don't know if Jillian will talk about it, but anyway, there is a lot going on with IBS. It's mostly diet that helped that, the FODMAP diet, I don't know if you heard that. And if it's ongoing for a while, it can give severe pain. I have it myself, and before I knew what it was, I had like severe pain that I couldn't eat because it gave me cramping, and I was like, what's going on? You feel bloated, you're passing more gas. And when you finally get on the diet, it will slowly get better. But IBS can be like mistake for other gynae problems sometimes. But like I said, it likes to be with endometriosis a lot. And bladder pain syndrome, or what we used maybe in the past, the interstitial cystitis, there's two names now for that. It's like an inflammation of the bladder. And it can give a lot of pelvic pain as well, and pain with intercourse, a bit like endometriosis. So it's all, sometimes it's not that easy to make the difference of, okay, which is what, because it's all at the same time. And bladder pain syndrome, people will have frequency, they will go pee a lot, they will have pain sometime before they go, like they have a full bladder, they feel like it's painful. And that is treated differently as well. It's usually by medication that help to control the pain. So, and sometimes we have to play on all that. People ask me, okay, how do I know if I have endometriosis? It's mostly clinical, I'll say now, because technically, the only way to really confirm it's a laparoscopy when you go see the pelvis. Ultrasound can miss it easily unless you have a cyst, a typical cyst we see with endometriosis. MRI that we thought would maybe helpful can miss it also unless it's really deep implants we call, so it's not guaranteed that it's helpful. It's laparoscopy, but again, since we cannot have access a lot to surgery, it's really difficult now sometimes to diagnose endometriosis for sure. So the treatments for pain with menses and endometriosis, they're pretty much, they look alike a lot. So usually we go along with the treatments to treat that. And if the pain is more present than just with menses, or it's really severe with menses, sometimes we say, okay, it's possibly endometriosis, but sadly, to confirm it for sure that you're having it, it's really difficult now because we don't have access to surgery. So, but we have to treat it as it is and reserve the surgery because we don't like to do surgery. Surgery risky, increase the risk of pain after because you create inflammation in your pelvis. That by itself can create more pain after. So we reserve it when we get pretty much through all the possible treatments and nothing's really work. And it's mostly to see, okay, why it's not working and see if there's nothing else to explain. But yeah, so in the past when I first trained, there's some medication that we used to give only after we did the laparoscopy. But now we have to go with those medications sometimes because we know that it's impossible before 2 years to have a laparoscopy. So it changed a little bit our ways to work, but we try to help the patient as much as possible. Any questions? I don't know how long I have and if I'm over or not. So I guess somebody will come to get me stuff if I. But she was here earlier, but she's gone, so I don't know. Any question? Yeah.
What about like ovulation pain?
It's something. Yeah, it is. Some people have, some people don't, and some people have it some months and not other months, and some people have it more on one side and the other side. Yes, it's what happened with ovulation is it creates the same kind of inflammation products that can create pain. And it's not like 1 month it's right, the next one it's left, and it's nah. It can be like full time on right, and then whoops, that's left. Full time of left, and then so it can fluctuate. And I don't know why some people will feel more one side and the other side. I'm like that. I feel it more when it's on the left side. I said, oh, must be that. It's like a heavy. Sometimes feel like it's heavy, crampy, and you walk, you feel like everything will. Anyway, it's known. The best thing for that, for sure, pills or anything that will control your ovulation will help for that. But if people are not on pills, the best thing again, it's Advil with Tylenol, Motrin with Tylenol. It's always better if you start before. I forgot to say that when you have a somehow regular cycle and you know you'll have pain, it's always better to start a day or two before your menses start to control the pain than waiting that the pain is there. When your cycle is not that regular, it's a bit more difficult, but ovulation pain is a thing, and it can be helped with medication, Advil and Tylenol. Or, like I said, anything that can play and stop more your ovulation, like birth control pills or patch ring, Depo-Provera, which will stop it. It can help with that, but it's a known things. But it depends at what age, because if you pass menopause, when there is atrophy, which is more frequent when you don't have the estrogen, you can have what they call a vaginitis. So it's not a yeast or a vaginal or anything like that, but like an inflammation that can have some odor and some discharge. But it's not an infection, so it's not treated with antibiotics or anything like that. It's more we have to take care of the dryness, which causes those symptoms. For women, it changed during the months as well, and like I said, there's multiple bacteria in the vagina, so sometimes it changes a little bit during the months, during your cycle, and can have a different odor. Unless it's odor that it's persistent, like it's not just overnight, but it's like a few days, and it's really like malodorant and like fishy or something like that, that's not normal. But there is an odor, it should not be at the point that it grows you out. That's what I say.
You wouldn't necessarily, I guess you shouldn't be recommending necessarily to see the doctor or...
Not if it's overnight. If it persists, I will say, if the odor is really bad and it persists, I will say yes, it's probably to see. And what I don't like sometimes as well is like, I'll prescribe you something, they don't even check or even do a swab or anything like that. So I see patients have been treated for I got multiple treatments for yeast infection. I'm like, Okay, what kind of symptoms do you have? Oh, it's itchy, it's burning, and it's painful. Okay, does anybody check you or did a swab to confirm it was a yeast? No, they just told me to go to the pharmacy and get that. Sometimes it's okay, but if it's persistent, you have to get checked, because a lot of women that I saw, I'm biased again because I'm seeing after a while, there's some skin disease, and we used to say when you get older, but now I see it at any age, called lichen sclerosis. And don't check website, because they will show you the horrible picture of someone never been treated in the worst case, so don't do that. But typically that this skin disease gives itchiness, burning, the same symptoms that you can have with a yeast infection. You don't have all the cottage cheese discharge, but you have all the other symptoms. And I saw a woman recently, she pretty had a good, not a good, but a bad disease that was really affected. And yeast infection, I have people saying, but when I took yeast treatment, it helped for 2-3 days and then it came back. Okay, I think the yeast infection treatments of canesten and all that may have maybe some of anti-inflammatory effects. That's why you had a bit of a relief, but since the basic disease is still there, it's never go away and it's coming back. And lichen sclerosis is one of them, and you can be good for a while, and then I have a wave that it's super symptomatic and having itchiness and pain. And so you need someone to check, okay, not just prescribe, because it's an ointment for that. It's not a yeast treatment. It's a specific cortisone treatment and ointment. And I see a lot of people that they get treated without having a sample, and that I'm like, or they treat me for recurrent bladder infection. Did you have an actual culture done at some point? Because bladder pain syndrome, like I said, or interstitial cystitis can give you the same kind of symptoms sometimes in the bladder infection, but taking antibiotics is not helping that. So it's why it's always coming back. And a lot of time, no, they just treat me because it looked like that. Okay, it could be fine, but if it's coming back all the time, you have to be assessed and have a culture. Is it really a bladder infection or it's something else? And it's just what I don't like sometimes. It's the people who treat without looking. And mostly the vulva, if it's itchy, burning, you do treatment and it's not going away, you need someone to have a look. It could be abnormal cells, could be a skin disease, you can have eczema there, you can have psoriasis there, you can have specific disease that won't be helped with yeast, or temporarily maybe a bit of relief and it's always coming back. So that's one thing, get checked if it's not going away. It might be really a recurrent yeast, but most of the time when I see those people, it's not that and it's something else. And I got the, so I'm done. So look at the website. Like I said, when you read the first one, they have a link to other stuff, or at the end, they will give you a link to other things that I find it's really good to give you a good impression of what to do and what can help. Okay? Have a good day. No problem.